Okay. আসসালামু আলাইকুম। আমি প্রফেসর লতিফা শামসুদ্দিন কথা বলছি। আমি আজকে আপনাদের ক্লাস নিচ্ছি। আমার গাইনোকোলজিক্যাল সাবজেক্টের আমার সাবজেক্ট হলো abnormal uterine bleeding. So I like to start the lecture just now.
ম্যাম প্লিজ আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।
আমি ডক্টর
শারমিন তুমি
শারমিন। ম্যাম প্লিজ আপনি ক্লাস শুরু করেন। আমরা আসলে মিউট থাকি তো এইজন্য আপনি মানে সাড়া পাচ্ছেন না যখন কথা বলছেন আমাদের।
না নেক্সট স্লাইডটা সরাবে কে নুসরাত তো নাকি? ইয়েস, অ্যাড্রেস টু দ্য স্টুডেন্ট, কোর্স নেম। আচ্ছা আচ্ছা ঠিক আছে। আমার এই কোর্সের নাম হলো পোস্ট গ্রাজুয়েট কোর্স ইন ফ্যামিলি মেডিসিন আন্ডার দ্য বাংলাদেশ ইউনিভার্সিটি অফ হেলথ সায়েন্স, ঢাকা, বাংলাদেশ। The time and date is 13/5/22. This is Friday, 9:30 and 11 a.m. Bangladesh time, 9:30 p.m. Thursday, USA. USA time now is 11 p.m. Okay, thank you. Next, abnormal uterine bleeding. The short name is AUB. Any uterine bleeding outside the normal volume, duration, regularity, or frequency is considered abnormal uterine bleeding. That is AUB. It is a symptom of an underlying problem. Actually, the previous name was DUB. Now the name is AUB at the moment. Next, pathogenesis of AUB. Anything that interferes with the cycling of hormones, normalcy of endometrial cavity. Number 3 is hemostasis. Any problem within these three can result in AU. So next one, prevalence. Estimated that AUB affects 10 to 30% of women, but 5 to 10% of women of reproductive age seek medical care for a heavy menstrual bleeding. Next one, menstrual history. Actually, for a menstrual history, we have to take in the sequence form, like frequency, then regularity, duration, and volume. Frequency, it can be normal, infrequent, or absent. Any of the three can happen. Common differential by the age is that 13 to 18 years is anovulation, 19 to 39 years is pregnancy related. This is the adulthood, and 40 and after 40 is the menopause. So anovulation occurs in 13 to 18 years of age. And next is the pregnancy periods and adulthood period, 19 to 39 years. The other causes of this disease is OCP problem, coagulopathy, tumor. The most common cause among the adolescents is persistent anovulation due to immunity and dysregulation of the HP ovarian axis, that is hypothalamus pituitary ovarian axis, and pelvic infection. This occurs in an ovulation period, this period between 13 to 18 years. After that, if it is 19 to 39 years, that is the adulthood, pregnancy can occur. Structural lesion, that is the tumor, leiomyoma, polyp, annular cycle, PCOS, OCP, endometrial hyperplasia, endometrial cancer. And after menopause, what happens is the anovulatory bleeding, endometrial hyperplasia or carcinoma, endometrial atrophy, leiomyoma. So these are the common differential diagnosis by age of AUB. Next. AUB, that is older classifications are like, next. Number 1 is dysfunction uterine bleeding. Uterine bleeding, diagnosis of exclusion. Then menorrhagia, heavy menstrual bleeding is called menorrhagia when the bleeding is more than 80 milliliter. Metorrhagia, bleeding between periods of irregular intervals excessive flow and duration. Polymenorrhea, that is bleeding that occurs more often than ever every 21 days. Oligomenorrhea, bleeding that occurs at an interval longer than 35 days. So these are the different types of the next one. Problematic definition, time for clarifications. Menorrhagia. What do you mean by menorrhagia? Menorrhagia bleeding more than 7 days or 80 milliliter at regular intervals. Then menometrorrhagia. That means irregular intervals, excessive flow or duration. Or then dysfunctional uterine bleeding. It means excessive bleeding that's excessively heavy, prolonged, or frequent of uterine origin, which is not due to demonstrable pelvic disease, complications of pregnancy, or systemic disease. Next one, please. Newer terminology. This can be heavy menstrual bleeding, replacing the menorrhagia. Irregular heavy uterine bleeding, replacing the menorrhagia. AOBE and ABO, replacing BO. So these are the newer terminology nowadays are used. Next. Heavy menstrual bleeding, that is excessive menstrual blood loss affecting quality of life, that is physical, emotional, social, and material. This is taken from the UK NICE guide. Next. Abnormal uterine bleeding. Dysfunctional uterine bleeding, that is excessive bleeding, excessively heavy, prolonged, or frequent of uterine origin, which is not due to demonstrable pelvic disease, complications of pregnancy, or systemic disease. So this is the name as abnormal uterine bleeding. Next. DUB. The may be classified without ovulation or according to the group into ovular bleeding and anovular bleeding. These two types of DUB. Ovular bleeding means of polymenorrhea, polymenorrhagia, oligomenorrhea, functional menorrhagia. That is ovular menorrhagia is quite uncommon. Next one is anovular bleeding. This is when there is no ovulation. Next, please. Anovular bleeding. This may be menorrhagia. Cystic glandular hyperplasia. That is, if you do the histopathology, you'll find the cystic glandular hyperplasia is present there in this case. Next. Palm coin or FIGO classification, that is 2011. In order to create an universally acceptable nomenclature to describe abnormal uterine bleeding, that is FIGO, International Federation of Gynecology Obstetrics, and American College of Obstetricians and Gynecologists, ACOG, introduced a near system of terminology to describe AOB. That is, the newer classification system is known by acronym PALM COIN, that is FIGO 2021. Next. Abnormal uterine bleeding. Again, the FIGO system and PALM coin system are together. This may be due to polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. Again, this may be submucous leiomyoma or other. And another one, that is the coagulopathy, ovulatory dysfunction, endometrial, then iatrogenic, not yet classified. So these are in combined classification from FIGO and American College of Physicians. Next one. Abnormal uterine bleeding, that is AUB, PALM classification and coin classification. Structural causes, that is the polyp, that is the tumor, adenomyosis, when adenoma within the uterine cavity. Leiomyoma, this can be of two types, submucosal or others. Malignancy and hyperplasia. Then coincides coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, non otherwise classified. So these two can be set together. Next one. There are some pictures by which we can show the type of tumor. Number one is polyp. Here you can see a polyp is coming from the fundus of the uterus. This endometrial or endocervical polyp can also happen, usually being, but a minority may be malignant, benign form, often asymptomatic, but some contribute to AUB. Polyp usually not as asymptomatic, but sometimes it can be. Next one. These are the pictures where you can see that adenomyosis, this endometrial tissue is inside the uterine body. It is within the muscle of the uterus, endometrium and other. The picture shows that prevalence of adenomyosis varies widely 5 to 70%. The diagnosis of adenomyosis is generally based on histopathologic evaluation of the depth of the endometrial tissue beneath the endometrial myometrial interlace in hysterectomy spaces. Actually, it cannot be diagnosed by other means except the biopsy after doing hysterectomy. However, ultrasound and MRI are increasingly used for diagnosis. This is used, but this is not the accurate way to diagnose. Next one, please. Oh, here you can see this is a cut section of a uterus after hysterectomy. And this cut section shows leiomyoma, a lot of leiomyoma. In the upper part, there is a big leiomyoma cut it into two, and lower part, there are some other leiomyoma which are present all over the body. Next one, please. Also described as myoma or fibroid. Prevalence is 70% in Caucasian and up to 18% of Domino African and, and, and can be asymptomatic also. Next. Oh, again, here we can see the different myoma in different position of the uterus. Submucosal myoma, you can see below the mucous membrane, and it causes heavy bleeding. Then intramural, it is inside the uterine body, that is in the muscle layer of the uterus. It causes extreme pain during menstruation. And subserosal, which is outside the serous membrane, it is usually pedunculated and does not cause any symptom. Then combination of all these can also happen in a single patient. So thank you. Next, please. Leiomyoma, that is classification system. Again, the same thing is coming. This is submucosal. It can be pedunculated intracavity. This is number one, 50% intramural. Then 50% number two is again intramuscular. Number three contains endometrium, 100% intramural. Number three, you can see intramural is 100%. Four, intramural. And then subserosal, plus minus 50% intramural. Subserosal, there's 50% intramural. Subserous pedunculated, that is the seven. Number seven is the subserous. Others are specified, that is cervical, it can be parasitic. So these are the different types of leiomyoma that we can see here. Next one, please. Malignancy and hyperplasia, that is AUBM. Here, the cut section of the uterus shows some abnormal type of cells. These are the malignant cells. There is no leiomyoma, there is no other specific tumor. This atypical hyperplasia and malignancy are important potential cause of or findings associated with the AUB. AUB can be with malignancy also. Next. Systemic disorder of hemostasis may be associated with AUB. This is coagulopathy. Actually, when blood does not clot automatically, and there is some pathology associated with this. 13% of women with heavy menstrual bleeding have a biochemically detectable systemic disorders of hemostasis, most often Willenberg disease. Next, ovulatory dysfunction, that is AUBO, heavy and irregular, that is absent ovulation, no corpus luteum, ovary does not secrete progesterone. Next one is continued estrogen stimulator without progesterone, stimulated withdrawal of bleeding. So these are the heavy and irregular bleeding. Next one. AOBO is associated with endocrinopathies. The endocrine system is always related with the menstruation, like polycystic ovary syndrome, hypothyroidism, hyperprolactemia, mental stress, obesity, anxiety, weight loss, or extreme exercise. All these causes as endocrinopathies related with menstrual abnormalities. Hello, next. AOBO may also be iatrogenic, caused by gonadal steroid drugs that affects the dopamine metabolism, such as phenothiazides and tricyclic antidepressants. Ovulatory disorders are more common in the extreme of reproductive age, that is adolescence and perimenopausal period. Next, please. Endometrial AOB, that is heavy and regular, caused by local disturbance of endometrial function. Then deficiencies or excessive of protein that have an impact on coagulation. Next, iatrogenic, that is intrauterine systemic or drugs that directly impact on the endometrium, interferes coagulation, or influences the regulation of ovulation. These are the iatrogenic factors. Next one, please. Intrauterine system and drugs, that is systemic gonadal steroids, estrogen, progestogens, and androgens, anticonvulsants, antibiotics, that is the rifampicin, and levogestinol releasing uterine system, copper T. These are the intrauterine system which affects the coagulopathy. Next. Interferes coagulation, that is drugs, warfarin, heparin, low molecular weight heparin, influences regulation of ovulation, like tricyclic antidepressants, that is amitriptyline and phenothiazides, drugs that inhibit serotonin uptake, etc. Next, not yet classified AOB. These are also another group, may include causes that have to be conclusive identified, such as chronic endometritis, arteriovenous malformation, myometrial hyperplasia, Caesarean scar on niche at the defect, niche defect. Next. Guideline for investigation. Actually, this is a very difficult job and you have to find out the way how to diagnose. Guideline for investigations are next. General assessment. For a diagnosis of chronic AUB, the patient should have experience in one or a combination of unpredictability, excessive duration, abnormal volume, or abnormal frequency of menses for at least three previous 3 months. Then we can say it is AUB. Next. History. If you take proper history, then we'll get the focus on details of the current bleeding episodes like length of bleeding, duration of bleeding, amount of bleeding, presence of clot or not, related symptoms that is dizziness or something else because loss of blood. Next one, post-menstrual or gynecological history. Then if it is a post-menstrual, then we have to know the pap smear result, recent surgery, previous medical treatment or gynecological disorders. These are relevant history. Next one, history, sexual history and contraceptives hormone use. Medical history, medications were like warfarin, heparin, NSAID, OCP, then gynesin, etc. Then personal history, like personal family history of bleeding disorders in a family. It can also correlate with this one. Next one, a structured history can be used as a screening tool for 90% sensitivity for detection of disorders of hemostasis. Positive screen comprises any of the following, like number one, heavy menstrual bleeding since menarche, postpartum hemorrhage, surgical related bleeding, bleeding associated with dental part. Next one, then physical exam is the vital signs, tachycardia, hypotension may signal acute hemodynamic instability and needs for rapid intervention. Presence of tachycardia, pallor, or heart murmur suggests anemia. This is the physical vital sign. Next is here petechial or excessive bruises. You can see the woman is showing in her head, face, and also hand, suggestive a platelet defect or other bleeding disorder. Obesity, acne, hirsutism, and acanthosis may also present in a patient with PCOS. So these are the physical examination findings I make it. Next. Then palpation of the thyroid gland for enlargement or other abnormalities. Because thyroid is mostly related with that of the menstrual disorder. Examination of the optic fundi and visual field testing, that is pituitary tumor, might cause this problem. Sexual maturity rating of the breast and assessment of the galactoria. Palpation of the abdomen, pregnancy, uterine, ovarian mass. It can be per abdomen or per vaginally, both the way you can palpate. Next, please. Then physical exam also includes external inspection of the genitalia is insufficient for diagnosis in most patients. A sexual active patient may warrant a complete pelvic examination. Can be speculum examination, it can be bimanual examination, by which you can see the size of the uterus, ovaries if possible, then fornices and cervix we can also see. So this is complete examination of the pelvis must be done. Next, laboratory evaluation. For the laboratory test number one, we have to exclude pregnancy by pregnancy test. Complete blood count, including differential count and platelet count. Blood grouping RH factor, TSH, prothrombin time, and activated partial thromboplastin time. One will in the studies also. There is factor 8 and others to be seen. These are the laboratory tests. Next. And then patient with a history of amenorrhea or irregular bleeding period to onset of heavy bleeding should have FSH and LH level, total and free testosterone level, dehydroepiandrosterone level, then prolactin level also to be seen. Next. Imaging, transvaginal ultrasonography, it's very important, sonohysteroscopy, and MRI. Only by these three tests we can say whether this is DUV or not. Next, other investigations like cytopathology, that is pap smear, cervical biopsy, hysteroscopy, endometrial biopsy, and surgical, that is D and C and E. So all these are the invasive tests we can do. And with this test, we can say what is happening with this woman. Next. This is the picture where we can see the chronic AUB, that is abnormal uterine bleeding. 3 months plus months of excessive duration, volume, frequency, and unpredictability. If it is not, then known chronic UB. This is not a case of chronic UB. If yes, then initial investigation, physical examination, and uterine evaluation is to be done. Initial investigation, that is structured history, ovulatory function, related medical disorders, medications, lifestyle factors, future fertility, screening for inherited coagulopathy. And again, initial investigation we have to do axillary investigation, actually like complete blood count, evaluation of endocrinopathy, testing for inherited coagulopathy if indicated. Next, please. Then uterine evaluation. Risk of hyperplasia and neoplasia we have to look for. If it is yes, then office endometrial, we have to work for endometrial biopsy. Adequate specimen, atypical hyperplasia, yes, malignant AOV. If no, then we have to think something else. It is the enhanced risk for structural abnormality, yes, transvaginal sonography, normal cavity, so nothing is there. No hysteroscopy and biopsy can be done. Targeted lesion cannot assess, so MRI is the last investigation that we can do. Next, please. Management. How to manage this woman? The general consideration, and there are some specific. In general, medical management should be initiated treatment for most of the patients. Its need for surgery, including type of surgery, is based on various factors. Stability of the patient, severity of bleeding, contraindications to med management, and underlying cause, desire for future fertility. Long-term maintenance therapy after acute bleeding is controlled. Actually, all these factors is to be considered before giving the final management. Next one. Initial approach to determine the AOB acute versus chronic. What type? If acute AOB are the signs of hypovolemia, hemodynamic instability. If yes, resuscitate the patient. How? By giving IV fluid, then crystalloid or colloid, then prepare blood transfusion. Once stable, then evaluate the case, and then we have to determine what type of treatment we are going to give to this woman. Next, please. Medical management, that is by hormone. First line of medical therapy for IOB is patient not known with bleeding disorders. Treatment options are combined oral contraceptive pill. Number two, progesterone therapy. Combined contraceptive pill includes estrogen and progesterone together. And only progesterone therapy, it can be in the injectable form, medroxyprogesterone assisted, or Provera 2.5 to 10 milligram daily for 10 days, 14 days, or it can be continued. Then Depo-Provera can also be given in injectable form. Levonorgestrel IUCD 5 years or implants can also be applied. This is the medical management. Next, conjugated estrogen. That is IV estrogen 25 milligram or 1.25. Then Pozistine local, Min- Mirena IUCD, the 20 levonorgestrel is daily for 5 years. Pozistine implantable, that is implanon is can be given. GnRH analog, danazol. Nowadays, danazol is mostly used. Next one, medical management for long-term use. They are used as inhibitors for fibrinolysis without significant increase in GIT side effects. They reduce virtually all cases of bleeding by 40 to 60%. The examples are tranexamic acid and aminocaproic acid. Tranexamic acid 1 gram 4 times daily for ovulatory DUB and prevent plasminogen activities decreases fibrinolysis. Medical management, yes. Next one, please. Medical management NSAID, the cyclooxygenase inhibitors, that is NSAID. Mefenamic acid is 250 to 500 milligram, 2 to 4 times daily. Also naproxen and ibuprofen for pain relief. Next, surgical management. Surgical management, we think last of all, it needs surgery, including type of surgery, is based on various factors like ability of the patient, severity of bleeding, contraindications of medical management, patient not responding to medical management, underlying cause that desire for future fertility. So these are the factors we have to consider before going for surgical management. Next, the options of surgical management are simple dilatation and curettage, endometrial ablation, uterine artery embolization, hysterectomy. Others include hysteroscopy with DNC, polypectomy, myomectomy. That is according to the cause you have to do the surgery. But first of all, the DNC and curettage must be done with biopsy. Otherwise, we cannot say what happened. Next one. Treatment options according to Palm and Cohen. So action depends upon the type of lesion, like etiology. If it is polyp, then hysteroscopic surgical removal of the polyp. This can be multiple, this can be single. This can be combined with the LNG IOD. Then adenomyosis. LNG IUS, this LNG IUS is not accepted. GnRH and agonist with add back therapy and NSAID progestogens, these are for adenomyosis. Malignancy, atypical endometrial hyperplasia, that is a surgical treatment. Continued fertility for desired hysterectomy. It is better, once it is malignancy, it is better to do hysterectomy. Then hyperplasia without atypia, LNG, IUS followed by oral progestin or PRAMS. Cohen says the LNG, IUS or tranexamic acid, NSAID followed by COS, cyclical oral progestin. Medical and surgical treatment fail or contraindicated GnRH agonist with add back hormone therapy. When steroid and other options unsuitable or meloxifene can be given. Next one, please. Treatment options according to the palm coin. These treatment are intramural or subserous myoma, tranexamic acid, yes, or COSA NSAID. In women over 40 years of age, fertility is not desired. A small fibroid is 4 to 5 in number. Medical management followed by hysterectomy can be done. Then short-term management up to 6 months, GnRH agonist with add back therapy followed by myomectomy. Long-term management is the LNG IUS. Newer medical option, ulipristal acetate or low dose mifepristol. Submucous myoma, that hysteroscopic or abdominal removal of the myoma. Next one. Thank you all for the time you have given.